Thank you. Hello, I'm Rachel Escher, pediatric endocrinology here at ANTHC, and happy to present with my colleague Pam Horan today. So thank you guys for having us. I do want to start by acknowledging that we are on Dena'ina land and to thank the people of this land. If you're interested in learning more, there's a really great Molly of Denali YouTube video about land back and whose land you're on. So it's a really cool place to check out. Neither of us have any financial interests or conflicts to disclose, although we will be talking a little bit about non-FDA approved use of medication and devices. So these are the objectives that we want to make sure and cover with today's talk. Pam will start by talking about just the AID systems, the automated insulin delivery systems that are available in the market right now, and how we might be able to use these systems to meet the diabetes management goals. And then I'll talk a little bit more about the process and policies that we developed in our hospital and what we've had success with so far and kind of how that relates to the current guidelines. And then we did pepper the talk with pictures from Diabetes Camp. So if you're interested in coming to Diabetes Camp and working at it, Pam and I are in charge of it, and we always want experienced volunteers.
Hello. So I feel like I get to talk about the fun part. I love to geek out on all the technology today. So we're going to start out, make sure everybody understands what the automated insulin delivery system is on kind of a basic level. But so this is kind of an outline of the goals from JDRF and the move towards an artificial pancreas. So a fully automated artificial pancreas is going to be that step 6 there. Looking at that, you have the dual hormones of both the insulin to help bring down blood sugars and glucagon in there if person's blood sugars are going low, so it can help keep them up to really try and optimize and keep a person in that target blood sugar range essentially all the time. We are not quite there yet. We have just in these last like 10 years really gone from a standard insulin pump where it was just programmed in settings to then having our first pump that could work with a sensor and detect when blood sugars were dropping and be able to suspend that insulin delivery. So that's our step 1 here to really try and help prevent a low blood sugar. And then be able to, again, use that sensor for step 2 and be looking out into the future and predicting when blood sugars are going to be causing a low blood sugar and shut it off before then. Right now, we are in about step 4 and 5, where it is a closed loop. And I'm going to go on to explain that a little bit more in detail. But we are still having to essentially initiate and announce to the pump when we're about to eat. So it delivers some insulin as we go into the meal period. But we are kind of in that stage of where that's not going to be as, people can get away without doing that and be able to still potentially maintain blood sugars in a somewhat normal range. What does the American Diabetes Association have to say about automated insulin delivery systems? Basically, it's the preferred insulin delivery method for youth and adults with type 1 diabetes. It is very effective and be able to maximize time and range. I have to say, when I started in peds endo, we had so many kids with A1Cs, 10s, 12, 14 plus, right? And I feel like those are white elephants at this, or that's not the right term. I feel like those are few and far between at this point because we can keep most kiddos in those single digits A1Cs now with these advancements in the technologies. It's really amazing. So this slide, I have to say, I'm not great at the microbiology and is a little intimidating, but what I really want to point out is that This is basically the cellular changes that go on in the cell, in the beta cell, in the presence of high blood sugars. And so the beta cell, as it sees glucose or senses glucose around it, the beta cell will start all these steps, all these different chemical steps towards producing insulin. And so it really is driven by that blood sugar reading. If blood sugar is high, then it's going to go through all the steps to help the beta cell release insulin out into the bloodstream to help manage the blood sugars. If that glucose isn't high, if levels are low, it's not going to initiate this chemical pathway towards that insulin production. And so for a person with a normal functioning pancreas, they can really have that tight control, keep blood sugars in a very narrow range, and not be experiencing symptoms of hypoglycemia, hyperglycemia. And this is the ideal thing with our technologies and our insulin pumps, is that technology can also achieve this, minimizing that hypoglycemia or low blood sugar, minimizing that hyperglycemia or high blood sugar, because it can respond in the same sort of way. So our scientists, our engineers that are developing these algorithms and these fancy mathematical equations to help the insulin pump do this, this is what they're trying to achieve. They're trying to really mimic what is physiologically going on in the body. Lots of steps here, but ultimately glucose sensing, insulin secretion. So this slide really is the one, though, that helps us to understand what is an AID system and how does it work. So in order for an AID system or artificial insulin delivery system to work, you need three components. You need the component of first a sensor to be actively sensing blood sugar readings. And these sensors are also predicting where blood sugars are going, not just where they are at that given moment. You need some sort of smart mathematical brain that these bioengineers have been able to formulate, so that based on the readings and what the sensor glucose trends are doing, that insulin adjustment can happen. And then along with that, we need our insulin pump, the source of where that insulin is coming from. So right now, they are just insulin pumps is the only medication in there, but we are advancing towards the future for a dual chamber pump with both the insulin and the glucagon to be able to help keep blood sugars ideally in that target range. So bringing this all together, just like in the pancreas or the beta cell in the pancreas, we want this AID system to operate in the same way. Glucose sensing is increasing the concentration in glucose. We are then sending that reading then to that smart technology brain. That smart technology brain then makes decisions on insulin delivery, whether it's pulling it back or increasing or ramping up that delivery, all in response to what that sensor reading is, and then telling that pump how to respond. So these are our 5 automated insulin delivery systems on the market these days. I'm not going to go into depth on each one of them, but they all are great products. And really, we want to help a patient or a person with diabetes identify which product works best for them. And so they all have different features. Their algorithms are a little bit different. You've got iLet where you don't have to carb count. You just tell the pump when you're about to eat if you're going to have your usual meal, less than usual, or more than usual. And then that algorithm, that smart brain takes over. Medtronic, they have one of their benefits is the missed meal detection, or I'm saying that wrong, the missed meal technology, where it helps you to try, and if you forget to announce that you're about to eat, you forget to do your insulin bolus before you eat, that can help take over and identify that and help enhance insulin secretion anyways. or insulin delivery, I should say. Omnipod, one of its great things is that you don't have tubes that connect it to your body. You're literally wearing a patch. And so a lot of people do like that. Tandem also is moving in that direction and has a little, that little black square kind of on the right-hand side. That's their new Mobi pump, in which it still has a little bit of tube, but you can very much wear it very much like a tubeless pump because it's a very short tubing and you can attach it with some adhesive sleeves anywhere on your body. And then their traditional pump, though, is the one on the bottom. That's the T-Slim X2. It has a very aggressive algorithm to it. And a lot of people are very happy with that and continue to stay with it. They were the first one that came out really with the ability kind of to stay always in that automated mode and give an auto correction. I should say Medtronic was, Tandem was close behind with some adjustments on it. And then Twist, I have to say, I'm not familiar with Twist at all. This isn't one that we've are using yet here, at least in our practice. We haven't spoken to a rep yet on this one. But this one will be connecting with the sensor, the Eversense. They're working on that joint, that relationship right now. Eversense is the sensor that's implantable, that implants for a whole year at a time. And so you only have to replace it once a month. They all have great benefits to them, and it's really matching the right system. But the right system to the qualities and the characteristics and the lifestyle of the person with diabetes. But they all have that ability that they connect with a sensor. They have a smart brain in them that responds and dictates insulin delivery. So if blood sugar is dropping, it's going to pull back on that background insulin and help to try and prevent a low blood sugar. If blood sugars are rising and you haven't given it any information to suggest that you just ate and why are blood sugars going up like this, it might ramp up insulin delivery to try and help reduce that high blood sugar after eating. All right. So as far as goals of diabetes management in the hospital, I would advise you to check out Standard 16 and the ADA Standards of Care. And if you guys aren't aware, the ADA Standards of Care are available as an app on your phone that you can keep handy with you all the time. But Standard 16 is where we're going to find. Okay. There is a lot of different levels as far as what it advises and for the inpatient care in the hospital setting. But one of the big things is that it recommends established protocols and structured order sets within the electronic ordering system, driving the care and the insulin dosing, medication management in the hospital. Another thing that it does recommend or say that CGM use should be continued during the hospitalization. Now, it is not currently approved for you to be able to do a CGM start or continuous glucose monitor start in the hospital, but to continue that care if it's something that you're doing at home. It still though does recommend that when we go to do mealtime delivery or insulin dosing, that we are doing a point of care finger stick check for blood sugar reading. It does not at this point say CGM or continuous glucose monitoring alone for blood sugar monitoring. And then it also does suggest that if you are on a insulin pump or an AID system at home, that it may be beneficial to continue that in the hospital setting. Right. There are some contingencies, though, at which we would say this is not an appropriate care to continue, whether acutely because a person's in critical care, or it could be that their mental status also is not there to appropriately monitor and function their pump while they are in there. It is something that a person is essentially maintaining control of their care and doing their own management when they are on a pump. It's not that traditional care that you would see in the hospital setting where the nurse, or I should say the physician's driving how much medication is being delivered, and then the nurse then carries out the orders on that medication delivery. The patient themselves is maintaining some autonomy and taking on some of that responsibility, a big portion, I should say, of that management and that care in the hospital setting when they maintain their insulin pump. There are management goals within that same. So these are taken from that standard 16 and the ADA standards of care. So glycemic goals for a critically ill patient is 140 to 180. In a patient that is not critically ill, that standard of care is 100 to 180 without hypoglycemia. So there are some contingencies there. If we're seeing a lot of hypoglycemia, then maybe we need to adjust that target while they're in the hospital. The goal is to also avoid hypoglycemia and severe hyperglycemia while in the hospital setting, volume depletion, electrolyte losses. By trying to maintain these blood sugar goals, particularly in the critical care setting, there's been a study out there showing a reduction in mortality rates of 40% when maintaining that type blood sugar compared to the old standards of like, I believe it was like 185 to 215 or something like that. It was quite high, or 250, quite high blood sugars. 40% reduction in mortality is huge. Also within the standards of care of ensuring adequate nutrition. We need to assess patient and family educational needs and address informational deficiencies. If there are deficiencies though, that make it unsafe for that person to manage their pump while they're in the hospital, then that would be a condition for not continuing the insulin pump therapy while in the hospital. And then ensure appropriate glucose management on discharge. I'm going to turn it over.
So in work towards achieving those goals, we know that as outpatients, just as Pam mentioned, we have been able to have a lot of success, or our patients and their families have had a lot of success with maintaining glucose levels within their target range using the automated insulin delivery systems, especially compared to all of the other systems that we have, because that, again, is closest to the function of the beta cell. And so, ideally, we could achieve some of these inpatient goals the same way by using the AID systems. And so there have been lots of advances in use of AID in the hospital. It is still not FDA approved to use AID systems in the hospital. CGM use is currently still not FDA approved for like consistent insulin dosing and everything. So the whole system itself, not yet FDA approved. However, there's been lots of studies, especially because of COVID, where we were trying to figure out ways to manage blood sugars and manage diabetes without as much patient interaction during COVID. So they was kind of used that horrible period of time to try to find some benefits for diabetes management. So there's been lots of different research. This Lancet article summarized a lot of the various studies. So I just used it to kind of lay out some of the studies that have been done to look at use of AIDs in the hospital. And so there were basically the sort of summary of this is that they did find benefit. So using AID systems, as you would think, people were able to show that it could be used safely, obviously number one importance, and that we could see less hypoglycemia, less severe hyperglycemia. And the biggest thing that people are worried about would be like, are we going to cause someone to go into DKA while they're in the hospital? And so they were able to find that it was safe to use with adequate training for the inpatient staff. Of course, these are all relatively small studies. Nothing's been done on a major scale. So that's one of the main reasons that's probably still not FDA approved, in addition to some other difficulties with just how operating the FDA works that we all understand. So lots of benefits and risks that have been understood because of these studies and just sort of our knowledge of the systems. But of course, we know that with these systems where we have the way towards an artificial pancreas is that then we're going to be able to make more real-time adjustments, right? So when you're using injections 4, 5, 6 times a day, based on a blood sugar that's checked 4, 5, 6 times a day, when there's how many seconds, minutes in a day, you're making adjustments maybe twice a day to what their insulin doses are. Versus with the AID system where it's always operating in the background without as much user interaction, you're going to have a lot more adjustments to achieve some of those glycemic targets. And then again, hypoglycemia prevention, especially for inpatients when maybe there's a lot of other people on the floor, or when people are busy and are not able to be constantly monitoring the blood sugar, or constantly with the patient in the room, having the system running in the background that's going to pull back on the insulin during as the sugar is dropping can obviously help prevent hypoglycemia and then prevent negative outcomes from that, which can have all kinds of benefits like improving sleep and decreasing or reducing time spent in the hospital and so forth. And also it just allows us to use the patient's home regimen, right? So that's obviously a benefit. It gives them their autonomy. It helps them use something that they're comfortable with. Already being in the hospital is a stressful, scary time. So if you can give somebody something that is a little bit less uncomfortable, it can make the hospital stay better. Of course, the risks are the things that we always worry about, especially in our healthcare system. We don't want to cause errors or have negative outcomes. So there can be things that can make the sensor data inaccurate or interfere with how the sensor and the pump are interacting. And so it does require probably extra checks, extra oversight compared to maybe what people are often doing at home. And the other big thing is training. So we may all be very well versed in use of these systems. The patient, their family, hopefully is well versed in using these systems, but inpatient teams, not necessarily, depending on kind of their level of interaction with pumps and system CGMs and diabetes before. So it does require a lot of training on everyone's side, which can potentially increase risk for errors if someone who is not well trained yet interacts with the system in an inappropriate way. Like I mentioned, COVID-19 was useful because there were a lot of opportunities for innovation, I think, during COVID, with telehealth and with all these other things. And so with diabetes too, there were some opportunities for innovation to improve care and also find ways to help the patient have more autonomy to decrease those interactions. And so there were several experiments. These are just two studies that kind of came out of that time. That was sort of one where they looked at CGMs and one where they looked at pumps, and kind of came up with a big kind of review and some practical guidelines in England. And so a couple of the things which hopefully these will be on the website, so I'm not going to actually go through it, but they did come up with kind of some algorithms, some decision trees about how to safely and effectively use these systems in the hospital for both pumps and for sensors. So people that are using wearable diabetes technology. So we were able to kind of, as we went through and developed our policies or improved upon our policies, we were able to use these studies and a few others to come up with that. Of course, there are some special circumstances that we will need to take into account as we developed our system and continue to improve our inpatient system. And then if other people are trying to make these policies as well. So acute illness, then the plans will change. What kind of nutritional status they have. Surgery and imaging are big ones because there are certain things that can interfere with the technology. So obviously I'm not going to read this. This is a table that I put together painstakingly. There was a great summary of how different radiology procedures interact with the different pumps and sensors from 2021, but it's 2025. So 4 years is like a century in diabetes technology terms. So I had to try to update it as much as possible. Keep in mind, so I put this out there so that, because it made it easier for me to remember which things could be used for what, but it might change in like 6 months because they're always trying to make you be able to wear stuff and not have to take it off. So how did we use all of this information, these goals and targets to come up with our system, our inpatient policy at ANTHC? First of all, I guess it's important to know that we first developed our inpatient pump policy. I want to say it was like 2014. I'm looking for the people who were here at that time with me, maybe 2013 even. So when I started here in 2011, we didn't have really any kind of inpatient policies for use of pumps, or obviously not for sensors, because that wasn't even really a big thing on the market yet. And so we first just developed an inpatient pump policy. But in the last couple years, especially kind of with these newer studies that were coming out, thanks from 2020 to 2023, and knowing how many more kids, in my practice, all patients are kids. So if I say kids, that means patients. So how many more kids are using AID systems, right? So it's exploding. We're basically trying to get everyone with type 1 and many people with type 2 who need insulin, or other types of diabetes who need insulin, onto these AID systems because of how superior they are. And so we want to be able to help them continue to use it in the hospital. So we developed a system to try to provide guidelines for the safe and effective care of patients on their AID systems in the hospital while staying in the hospital, and I'm allowing them to remain on the system that they are using in order to have a successful healing journey during their inpatient stay. Because we know that it improves outcomes, decreases error risk, decreases readmissions, decreases ER visits after discharge. We did develop some conditions that must be met to stay on their AID system. First, they just need to be able to operate their pump and their CGM. If there's no one there, the patient or their parent or guardian who can operate the system, because our inpatient teams are very, very smart, they're very skilled, but they are not necessarily experts in these systems. Especially, we just showed you there's like how many pumps and CGM systems out there, and they all operate a little bit differently. We did not want to put this burden onto our inpatient nurses and physicians. And so they must be in a place where they can operate it independently within the oversight and documentation by the inpatient team. So that then must mean that they have to be mentally appropriate. They cannot be in sort of a critical care situation where maybe they're not awake all the time, or they're not fully with it in it from a mental status place. And then there has to be obviously the supplies available that are not expired, that are all working correctly, that are the correct supplies, all of that. And then because of that, we did develop an agreement, kind of consent system for the family and the patient to go through with the team. And then the provider who is attending to the child also needs to then agree, and usually we'll work with the consultant to make sure that they are appropriate for use of these systems while in the hospital, and then use our computer and order system for it. So speaking of, so these are sort of the responsibilities that we have laid out in our policy. The provider, once they find out that someone's on a pump, they will consult with the consultant, the pediatric endocrinologist, the adult diabetes team, to determine if they are appropriate for this. And if so, then they'll put the orders in. So that also then led us to a whole big, long process of developing and updating and improving our inpatient order set for pumps, because as you all know, it's quite different from doing injections, right? So we did have to make big updates to that as we developed this policy. Of course, the provider then will enter orders, respond to any changes in their status, like if they become acutely ill or if they're going to have surgery or some kind of a radiology procedure or whatever, and then also manage anything that might happen while on these systems like sick days or pump failures or whatever. For nursing, they have a lot more responsibilities. Thank you, nurses. And so first of all, on admission, there's going to be a lot of things that they'll have to do that are extra with these systems. So in terms of making sure that they have all of the supplies, that they are equipped and capable of managing it, that the supplies aren't expired, and then going through the consent process. During the hospitalization, we felt like the best times to kind of check the pump, make sure it was still operating, make sure it was in automated mode. If it's one of the pump versions that kicks you out or exits you out of automated mode, make sure that their mental status is appropriate for continuing to use the pump. All of those things, we felt like the best times to have those checks were at the mealtime boluses. So, because that's the time when they're interacting most with the patient and with the pump. And so during those mealtime boluses is when you're going to check and make sure the pump is still active, make sure the basal is still running. That's when they're going to document, obviously, the carbs, the blood sugar, how much insulin is going to be given for boluses. And then also that's a great sort of time to make sure that the patient and parent are using it appropriately, kind of like a double check that everybody knows what they're doing, essentially. Lots of documentation, obviously, in the hospital. So we did make some policies around documenting basal rates when those are available, or documenting the total daily basal given at that moment in time, depending on what kind of a system they're on. And then thinking about site changes. So, you know, how often does this pump need to be changed? Is there still enough insulin in it? Even if they usually change it 3 days, maybe they've been sicker, so they've been getting higher amounts of sugar and they need to change it sooner. So all of these things also need to be documented. And then currently with our current policy, we are also having a 4-time point of care blood glucose finger stick checks done as well, to sort of validate the CGM, because it's still not currently FDA approved to use CGM solely in the hospital. And then the patient and or guardian responsibilities then are continuing to be able to use and operate the pump as expected, and help with bolus dosing. We put it in our process that the patient or parent, guardian, are the people that are actually interacting with the pump. They are the ones that are entering the numbers, pushing the buttons, whatever kind of a system it is, they are doing it, and the nurse is watching. And then the nurse documents what has been done, but the patient is actually the person interacting with the pump, because it's their body, it's their diabetes, it's their devices. They know how it works the best. And so if they are not capable of doing that, then that again is a contraindication to using it in the hospital. And then of course, providing their supplies. And we did have to specify multiple times that their supplies are not expired, because how many times do people come in and it's like expired? So these are the agreements that Pam developed. We did kind of borrow from many other inpatient systems to develop these patient agreements. These are basically components of the agreement. Number one component is that they will communicate. So nothing happens without the nurse present. It's just like a diabetes camp. It's a little bit different from home. You don't do stuff without telling the person that actually has to document it and take responsibility for it if something goes wrong, right? So that was a big part of our patient agreement, was that they're not going to bolus without talking with the nurse or discussing it with the nurse, having that kind of that second double check approved. Again, just demonstrating that they know how to use the devices safe and effectively, and providing the supplies from home, changing everything according to the recommendations, and then right now with our current policy, they also have to agree to those 4 times a day blood sugar checks with the finger stick, even though they still have their CGM in place. Because they're coming in with their own insulin, we did not want to make people change their site upon admission. And so we agreed that they could continue to use their own insulin that's already in their pump. And then when we do their first site change in the hospital, whatever day that is, then we'll use our inpatient supply of insulin. And so they also have to agree to that. And then again, we're not going to be changing anything without provider orders. We are in the process of working on our CGM policy. So I worked really closely with Leslie Bagley, one of the providers over at Providence, because they were also kind of in tandem developing this their own policy, and so we worked together to not reinvent the wheel. So in many of the guidelines that, even though it's not FDA approved, where they are working towards using CGMs without having to do point of care blood glucose testing. So many of the research articles and then the guidelines that were developed from all of those studies and the CGM studies during COVID, we're talking about validation. And so basically kind of this decision tree here, first of all, makes sure kind of all those double checks that someone is capable of using their system, and then that the CGM is working correctly, which we then will validate with our hospital meter for the first so many checks. And then once it shows that the CGM seems to be working correctly, once we finish this process, which was started a year ago, they will not have to do those 4 point of care blood glucose checks anymore once it's been validated. So that's kind of the goal with our CGM policy that we are working towards. Currently, in our policy, the only people that are allowed to continue using their CGMs are the people who are on AID systems. We have gone a case-by-case basis if they can continue to wear their CGM otherwise, but they aren't able to use it for anything if they're not on an AID system. And so this will then allow us to continue using CGMs for everybody in the hospital, whether or not they're on the AID. So I mentioned one of the biggest safety challenges is education and training, because many of our inpatient staff do not have the experience with all these different pumps and CGMs and devices. And so Pam did some trainings with the inpatient nurses, and then I did some trainings with the physicians in order to just introduce them to these devices, kind of let them know how it works. One thing we hate to do is for someone to just see something on somebody's body and not know what it is, right? Is it a pump? Is it a CGM? Is it both? I hate for people to be like, yeah, they have something on their body and I don't know what it is. So we just want to help with people understanding that and know kind of the basics of how it works, and then know what our policies are in terms of who can use it and how should they use it. So the training really went over kind of all of those systems. Pam also kind of just went over just basically what is diabetes and sort of the different ways of treating type 1 diabetes in the hospital, and then understanding the devices and the technology. And then with kind of thinking about other sort of those special circumstances like radiology procedures, bathing, showering, kind of how are we handling things if something comes out, and so our pump failures, et cetera, and kind of what the rules are. So that is the system we developed. Happy to take any questions. This is our last diabetes cap picture. So, and then, this is how to reach us. This is our team, our very much expanded team at ANTHC that we are working on expanding even further. So we do now have access to see all Native and non-Native patients across the state.
Hi, we have a pump policy at our hospital in Fairbanks, but we have more of it's for adults. We don't do a whole lot with peds, but we had a patient one time that is, I think they're on the new Omnipod that has a very different kind of algorithm, which was very hard to chart because it often boluses by itself or
Right.
how that works. And so I was wondering how you guys have tackled that kind of thing.
So with all of the AID systems where they have the auto boluses or the auto basal or those kind of adjustments, we are not charting those. All we are charting is our user interaction. So the boluses, that's like the boluses that's happening with meal times. And then the other thing that we're charting, or not me, I don't do it. The nurses chart is the basal. So with the Omnipod, there's no basal, but you can see what the total daily basal was in the history. So they're charting what's in the history for that day. And we're having them do that, I think, once a shift. And I might be wrong, actually, how often, I can't actually remember. I have to look at the policy again. Once a day, did we decide? Yeah. Total daily, once a day. But yeah, so we just are only user interaction and then the basal on the Omnipod. Yeah. And I think the eyelet similarly, that's going to be tricky when we have somebody on the eyelet. Did I say any other things, Pam, about that one? Well, I guess we just